Every 3 seconds, somewhere in the world, a new case of dementia is diagnosed. By the time you finish listening to this, dozens more families will be sitting in a doctor's office hearing the words nobody ever wants to hear. And for a frightening number of them, the trigger was never genetics. It was never just age. It was something they swallowed every single morning with a glass of water, trusting it completely, because a doctor told them to. I've spent over 15 years in clinical practice, and one of the most heartbreaking patterns I see is this. A patient who was sharp, independent, quick-witted their entire life starts to fade. They forget a grandchild's name. They get lost driving to the grocery store they visited for 30 years. They repeat the same question 4 times in an hour. And everyone around them, the family, sometimes even other doctors, they all shrug and say the same thing. It's just age. It wasn't age. It was sitting right there on the nightstand. A pill. Sometimes 2. Sometimes 5 pills working together to do something nobody ever warned them about. Here is what the research now makes very clear. Certain common, widely trusted medications can accelerate cognitive decline so aggressively that within a single year, a perfectly sharp 65-year-old can begin to look like someone in the early stages of Alzheimer's disease. And the worst part is that most of this damage, when caught early enough, is reversible. But it is almost never caught early because almost nobody thinks to look at the medication list. Today I am walking you through 9 medications most strongly linked to increased dementia risk after age 60. I have arranged them from the ones people overlook most easily all the way up to the single most dangerous pattern I see in my practice, the one that may be responsible for more preventable cognitive decline than anything else on this list. Pay close attention to number 3. It is taken by millions of seniors every single day for a condition that barely sounds medical. And the latest research suggests it may be quietly dissolving your ability to form new memories right now, with 0 warning signs. Before we begin, drop your age in the comments and tell me how many medications you currently take each day. I read every single one, and what you share directly shapes the topics I cover next. Let's begin with number 9. And do not let the low ranking fool you, because this one is in nearly every medicine cabinet in the country, and almost nobody considers it dangerous. Number 9 is diphenhydramine. You know it as Benadryl. That small pink pill people reach for when allergies flare up, when a cold won't quit, or when sleep just will not come. It is cheap. It is everywhere. No prescription needed. And because of that, most people assume it is essentially harmless. Inside the brain of someone over 60, it is doing something remarkably aggressive. Benadryl belongs to a class of drugs called anticholinergics. That is a technical word for a very simple concept. These drugs block a brain chemical called acetylcholine. Acetylcholine is the messenger your neurons use to form new memories, to stay focused, and to keep your thinking sharp throughout the day. After age 60, the brain produces less and less of it naturally. Every molecule becomes more precious. So when a drug comes along and blocks what little remains, the impact on an older brain is vastly heavier than it would be on a younger one. The structure that takes the hardest hit is the hippocampus, the seahorse-shaped region deep in the brain where new memories are created and temporarily stored before being filed into long-term storage. Suppress acetylcholine there, and the filing system starts to break down. A 2023 study published in the Journal of Geriatric Cognitive Health followed older adults who used anticholinergic medications on a regular basis and found they had a 54% higher risk of developing dementia compared to people who avoided those drugs entirely. More than half again the normal risk. From something people treat like a vitamin, here is what I need you to do. Go to your medicine cabinet tonight and read the active ingredient on anything labeled PM, nighttime formula, sleep aid, or allergy relief. Many of those products are simply Benadryl repackaged under a different brand name. If you need allergy relief, newer antihistamines like loratadine, sold as Claritin, or cetirizine, sold as Zyrtec, do not cross into the brain the way diphenhydramine does and are far safer for anyone over 60. Do not stop anything abruptly on your own. Bring the bottle to your next appointment, but stop assuming that over-the-counter means safe for your brain. That assumption is costing people years of clarity they did not have to lose. That is number 9. Number 8 is something your stomach may feel grateful for, but your brain is quietly paying the bill. Number 8 is the proton pump inhibitors, commonly known as PPIs. The names you would recognize are omeprazole, sold as Prilosec, and esomeprazole, sold as Nexium. These medications shut down acid production in the stomach and they are prescribed for heartburn, acid reflux, and that burning discomfort after meals. Millions of people start taking them for what is supposed to be a few weeks and then never stop because the moment they try, the acid comes roaring back even worse than before. So the pill becomes permanent. A decade goes by. Nobody revisits the decision. Here's the part that rarely makes it into the conversation at the pharmacy. Your stomach needs acid. It uses that acid to extract critical nutrients from the food you eat. Among the most important is vitamin B12, which your brain depends on to maintain the protective coating around every nerve fiber. That coating is called myelin, and without it, signals between neurons slow down, misfire, or fail entirely. Suppress stomach acid long enough, and B12 levels quietly drop. Magnesium and calcium follow. These are minerals your brain cells need to fire properly, to communicate, to stay alive. Starve the brain of those raw materials for long enough, and you get confusion, word-finding problems, and memory lapses that look exactly like the opening stages of Alzheimer's disease. Except the cause is not a degenerative brain disease at all. The cause is a nutrient deficit created by medication. In 2016, a major study in JAMA Neurology examined more than 73,000 adults aged 75 and older. Those who used PPIs regularly had a 44% higher risk of dementia compared to non-users. And the research went further. PPIs have also been shown to increase levels of amyloid beta in the brain, the sticky protein that accumulates in the brains of Alzheimer's patients. So here is the path forward. If you have been taking a PPI every day for months or years, that is a conversation your doctor needs to hear. Many people can taper down to a milder class of acid reducer called H2 blockers, such as famotidine, sold as Pepcid, which carries far less cognitive risk. Some patients find relief with deglycyrrhizated licorice, a natural compound that coats and soothes the stomach lining without any impact on the brain whatsoever. The principle is simple. The lowest dose, for the shortest time, with regular reassessment. Not a pill you swallow on autopilot for the rest of your life. Number 7 is prescribed for a problem most people find deeply embarrassing to discuss, which is exactly why it so rarely gets questioned. Number 7 is oxybutynin, sold as Ditropan. It is given to older adults who deal with overactive bladder, that sudden urgent need to reach the bathroom immediately. The kind of urgency that can reshape an entire day, that can keep someone trapped inside their home, afraid to go anywhere without knowing exactly where the nearest restroom is. The relief this medication provides is real. The dignity it restores is real too. But oxybutynin works by blocking acetylcholine, the exact same memory chemical we have been talking about. And this particular drug crosses into brain tissue with alarming ease. Once there, it parks itself in the hippocampus and stays, suppressing the very chemical processes that allow new memories to form. In 2019, the British Medical Journal published a study of adults over 65 who had taken strong anticholinergic medications like oxybutynin for longer than 1 year. Their risk of dementia was 49% higher. Nearly 1 in 2. And here is what haunts me about this one. Almost none of those patients were ever warned. They were told the pill would calm their bladder. Nobody mentioned it might be dimming their mind at the same time. The fog gets blamed on aging. People describe forgetting appointments, misplacing their keys 10 times in a single day, losing the thread of a conversation halfway through a sentence. Everyone around them nods sympathetically and says, well, that is just what happens when you get older. It is almost never traced back to the prescription until significant cognitive ground has already been lost. If you take oxybutynin and you have noticed your memory becoming less reliable, take that seriously. You do not have to choose between your bladder and your brain. A newer medication called mirabegron, sold as Myrbetriq, works through an entirely different mechanism and does not block acetylcholine at all. For most older adults, it provides comparable bladder control with far less risk to cognitive function. Bring it up at your very next appointment. Number 6 may be the most surprising entry on this list because it involves one of the most widely prescribed classes of medication on Earth. Number 6 is statins. Simvastatin and atorvastatin, sold as Zocor and Lipitor, are taken by tens of millions of adults worldwide, especially after age 60. And they serve an important purpose, lowering cholesterol and reducing the risk of heart attack and stroke. Statins belong in many people's treatment plans, and nothing I say here is intended as a blanket case against them. What follows is the part of the story that almost never gets told. Cholesterol is not merely a villain in your arteries. Your brain is nearly 60% fat by dry weight, and it depends on cholesterol to build myelin, the insulating sheath wrapped around every nerve fiber that allows electrical signals to travel quickly and cleanly. Reduce cholesterol aggressively enough with a potent statin, and you can leave the brain short of a building material it genuinely needs to function. The statins that cause the most concern are the lipophilic ones, the ones that dissolve in fat and cross easily into brain tissue. A 2023 study published in Frontiers in Aging Neuroscience found that adults over 70 who had taken lipophilic statins for more than 3 years showed a 26% higher rate of mild cognitive impairment. The higher the dose, the steeper the decline. Some patients describe episodes that are genuinely frightening. A familiar name gone. A conversation they finished 5 minutes ago completely erased. A route they have driven for 2 decades suddenly feeling foreign. The critical thing to understand is that not all statins carry equal risk. Pravastatin and rosuvastatin are hydrophilic, meaning they do not cross into brain tissue as readily, and they are generally considered safer choices for preserving cognitive function while still protecting cardiovascular health. So if you've been on a lipophilic statin for years and you are noticing fog, forgetfulness, or mental confusion creeping in, that is a legitimate conversation to have with your doctor about switching to a different statin or adjusting the dose. It is absolutely not a reason to stop your medication quietly on your own. Heart protection matters enormously. The goal is to protect both your heart and your brain, and with the right guidance, that is entirely possible. Quick pause. If this is connecting dots for you that nobody else has connected before, take 1 second and hit that like button. It genuinely helps push this information out to more people who need to hear it. And while you are down there, tell me in the comments how many prescriptions you are currently juggling. I read every single response. All right, back to the countdown. Number 5. Number 5 is the benzodiazepines. Lorazepam, sold as Ativan. Diazepam, sold as Valium. Alprazolam, sold as Xanax. These are among the most commonly prescribed medications in the country for anxiety, panic, and insomnia. They work by amplifying GABA, the brain's primary calming signal, the chemical that turns down an overactive nervous system and quiets the noise. At first, they can feel like a miracle. The panic dissolves. The racing thoughts finally slow down. Sleep arrives for the first time in weeks. That initial relief is powerful, and it is exactly why these medications become so difficult to leave behind. But over time, the picture changes in ways that are difficult to see from the inside. A 2022 study published in the British Medical Journal followed more than 8,000 older adults over 6 years and found that those who used benzodiazepines for longer than 3 months had a 51% higher risk of developing Alzheimer's disease. The longer-acting formulations, such as diazepam, appeared to carry even greater risk because they linger in the body far longer and accumulate in fatty tissues, including the brain itself. What these medications create is a slow, sustained chemical sedation of the entire brain. Learning becomes harder. Mental flexibility declines. Reaction time stretches. Many people describe a pervasive emotional flatness, a sense of moving through life behind a thick pane of glass, no longer feeling fully present or fully themselves. And then comes the cruelest part, the exit. If a benzodiazepine is stopped abruptly, anxiety and insomnia can return with a vengeance far beyond what the person experienced before they ever started the medication. Agitation, tremors, even seizures can follow an abrupt discontinuation. That rebound effect makes the drug feel absolutely indispensable at exactly the moment it may be causing the greatest harm. So here is the rule, and it is non-negotiable. If you have been taking a benzodiazepine for more than a few weeks, do not stop suddenly. Doing so can be genuinely life-threatening. Work with your doctor to taper gradually over weeks or even months. There are alternatives. Buspirone, for example, can address anxiety without sedation or cognitive clouding. Cognitive behavioral therapy for insomnia, which is a specific structured form of talk therapy, has been shown in multiple studies to be as effective as medication for chronic sleep problems, with zero risk to the brain. The path off these medications exists. It just requires patience and professional guidance. Number 4 carries one of the heaviest hidden cognitive burdens on this entire list, and it is prescribed for 3 completely different conditions, which is exactly why it shows up everywhere. Number 4 is amitriptyline, sold as Elavil. It is a tricyclic antidepressant that has been around for decades. Originally developed for depression, it is now widely prescribed for chronic nerve pain, persistent headaches, and stubborn insomnia. That versatility made it one of the most commonly used medications in older adults. A single pill that seems to address multiple problems at once. But beneath that apparent convenience, amitriptyline is one of the most potent anticholinergic drugs still in routine use. It blocks acetylcholine so aggressively that with sustained use, memory problems stop being a possible side effect and begin to look like an expected outcome. In 2015, a landmark study published in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older over a decade. Those with the highest cumulative exposure to strong anticholinergic drugs, including amitriptyline, had a 54% greater risk of developing dementia. And virtually none of them were ever informed that their medication could do that. They were given the pill for sleep or for pain. Then, year by year, they noticed words slipping away, memories thinning out, concentration becoming harder to hold. And they blamed themselves. They blamed aging. They never once looked at the pill. It does not even require a large dose. A small nightly dose taken consistently over years can erode cognitive function so gradually that the decline feels natural, like something that was always going to happen, when in reality, it was being manufactured 1 tablet at a time. If you or someone you love takes amitriptyline, that conversation needs to happen soon. For nerve pain, medications like duloxetine or gabapentin may provide comparable relief with a far lower anticholinergic load. For sleep, low-dose melatonin or very low-dose doxepin, which is significantly gentler on the acetylcholine system, may be viable alternatives. For depression, newer antidepressants such as sertraline or escitalopram are broadly considered much safer for the long-term health of the aging brain. Number 3. This is the one I told you to watch for at the beginning, and it deserves your full attention because it is prescribed to millions of people for something that sounds entirely benign. Number 3 is paroxetine, sold as Paxil. It belongs to the SSRI family of antidepressants, a class of medications that is widely regarded as modern, well-tolerated, and safe. And for most SSRIs, that reputation is largely earned. But paroxetine is different. It is the one SSRI that carries significant anticholinergic activity. That single property separates it from its relatives like sertraline and escitalopram and places it in a category of risk that most patients and many prescribers do not fully appreciate. A 2021 review published in Frontiers in Psychiatry examined older adults taking various SSRIs and found that those on paroxetine showed measurable declines in short-term memory, word recall, and sustained attention within the first 12 months of use. Seniors taking paroxetine were 30% more likely to show early signs of cognitive impairment compared to those taking other antidepressants in the same class. There is a painful irony buried in that finding. The medication is prescribed to stabilize the mind, to lift someone out of the darkness of depression, to restore clarity and function. And over time, it may quietly erode the very clarity it was supposed to protect. The solution is straightforward. In older adults, paroxetine is generally a medication worth replacing when alternatives exist. The American Geriatrics Society placed it on the Beers list, which is a formal catalog of medications considered potentially inappropriate for seniors. Paroxetine appears there specifically because of its anticholinergic properties and cognitive risks. If you take it, talk to your doctor about switching to a safer SSRI such as sertraline or escitalopram. These medications treat the same conditions with a gentler profile and without the same threat to memory and thinking. Supporting adequate levels of B vitamin, particularly B12 and B6, may also help stabilize mood through and beyond the transition. Number 2 is prescribed so quietly, so routinely, that many of the people taking it do not even realize what category of drug it belongs to. And that is what makes this one so deeply troubling. Number 2 is antipsychotic medications. The names include quetiapine, sold as Seroquel, risperidone, sold as Risperdal, and olanzapine, sold as Zyprexa. These drugs were originally developed and approved for serious psychiatric conditions like schizophrenia and bipolar disorder. They are powerful medications designed for powerful illnesses. Today, however, they are routinely prescribed off-label to older adults for insomnia, mild agitation, restlessness, or behavioral symptoms associated with early dementia. In nursing homes and care facilities across the country, medications that were built to manage severe psychiatric crises are being handed to elderly people who are simply confused, anxious, or difficult for overworked staff to manage. The cognitive cost is staggering. A 2022 study published in Lancet Healthy Longevity followed more than 25,000 older adults and found that those given antipsychotic medications for behavioral symptoms were 71% more likely to experience accelerated cognitive decline within a single year, even when they had no prior diagnosis of dementia before the medication was started. These drugs suppress dopamine, a neurotransmitter involved not only in mood and motivation, but also in focus, planning, learning, and memory formation. Reduce dopamine output far enough, and the brain becomes slower, quieter, and less responsive. That is why some individuals on these medications appear dull, emotionally flat, or almost absent. Their families watch someone they love gradually disappear while still being physically present, and they assume the disease is progressing, never suspecting that the medication itself may be accelerating the very decline they are watching. These medications also raise the risk of stroke, sudden cardiac events, severe sedation, dangerous falls, and hospitalization. If you or a loved one is taking an antipsychotic, the first step is a direct and honest question to the prescribing physician. Why was this started? Is it truly necessary? Or is it being used primarily for behavioral management and convenience? Many of the behaviors these drugs are used to suppress, the restlessness, the agitation, the sundowning, can often be significantly improved without medication at all, through consistent daily routines, reduced noise and overstimulation, treatment of hidden pain that the patient may not be able to articulate, and better management of sleep cycles and environment.